So in the second part of week 2, we're going to continue our discussion on the types of economic evaluation that we use in healthcare. This week we're going to look at cost effectiveness analysis and cost utility analysis. And I would like to say that in many studies you'll find them titled as the cost effectiveness of so and so. This is not a reference to the type of economic evaluation. It's a reflection of the general nomenclature of these kinds of studies. So even a study that is technically a cost utility analysis will be titled in the literature cost effectiveness of so and so. So that's something that we need to remember, and I'll keep on reinforcing this message as we go along. But a cost effectiveness analysis essentially measures outcomes in natural units. So if you had an antihypertensive medication, the outcome of interest might be millimeters of mercury reduced of blood pressure. If you have a diabetic medicine, you might have the intermediate outcome HbA1c, and you're interested in the cost per percentage reduction in HbA1c. Now, life years also, without combining them with quality of life, are considered to be outcomes of cost effectiveness analysis because they are natural units. So the cost per life year saved is a cost effectiveness analysis metric. Now, it examines the costs of alternatives to achieving a specific health objective. So you can do this kind of study in a single indication, comparing antihypertensives or comparing anti-diabetics. And it essentially identifies the least cost way of achieving this objective, your stated objective. It's relatively easy to communicate. The problem is that you can't compare interventions across the health sector. And the reason is you can't index both quality and length of life. And if you have a mortality-heavy intervention, like I gave the example of helmets for reducing accidents and mortality, to antidepressants, which don't have an immediate mortality benefit, then you can't compare these kinds of different interventions. Here's an example of a study that we did some years ago of a cost-effectiveness analysis. In the last part, I gave an example of a cost minimization in which we compared the costs of following up HIV patients. The big weakness in that study was that we assumed that outcomes would be the same if doctors or nurses saw patients on a month-to-month basis. But this might not be the case because doctors are maybe better trained and they're more able to respond, to recognize and respond to adverse events of medication, or to even new opportunistic infections. So maybe seeing doctors is better. And even as an individual, you might prefer to see a doctor on a month-to-month basis if you had a disease. So we did this study, which was a cost effectiveness analysis, and the outcome was in natural units. And the background was the same as the other one, as you know, severe health worker shortages. And the IDI clinic in which I used to collaborate and did some work had a program called the Pharmacy Only Refill Program, or PRP. And that was the first comparator, and we compared it to the standard of care. And the standard of care was patients being seen on a month-to-month basis by doctors. So we did a retrospective cohort analysis for the outcomes assessment, and the outcome was favorable immune response, FIR, and it was measured as having a CD4 count of less than 500 cells per microliter. And we did a standard AP analysis, a multivariate logistic regression, to see whether the standard of care and the PRP differed in favorable immune response at 1 year. And we used these estimates to do the cost effectiveness analysis. So here are the results of the study, the retrospective cohort analysis. So the study population, you will see that they were relatively young people. In the standard of care, you had people who were a little bit older than in the PRP on the age there. And generally speaking, there are more women who have HIV in this clinic. And here are the regimens that they started on, and here are the regimens that they were on currently, and the number of opportunistic infections and adherence rates and the CD4 count. And the CD4 count was relatively similar between the groups when they were starting out. So this was a description of the study population. And when we did the logistic regression, we found that after adjusting for different confounding variables, there was a small reduction in the probability of favorable immune response if you are being followed up with a pharmacy refill program. But this reduction was not statistically significant. So technically, the outcomes were equivalent. But as we saw in the last part, the disadvantage of cost minimization is that you can't assess the joint distribution of both costs and effects. And so in this study, despite the non-significant difference in the probability of favorable immune response, we wanted to examine the joint distribution of costs and outcomes in a cost effectiveness analysis and see the cost effectiveness of comparing the standard of care and the PRP. So we went ahead and did the study, and this is results of the cost effectiveness analysis. And again, we had two perspectives, and as I said, we're going to examine the question of perspective next week. But in US dollars, from a societal perspective, the standard of care was $655. The PRP was cheaper, so it reduced cost. And most of those cost savings are based on the fact that in the standard of care, you have doctors who are more expensive, and in the PRP, you have nurses and pharmacy workers who are a bit cheaper. So there was a reduction in $135. And then from the perspective of the Ministry of Health, which is what we are calling healthcare costs, it was a reduction of $114 here. And then the outcome, which is a true clinical unit, favorable immune response, which makes the study a cost effectiveness analysis, there was a reduction in 0.01, which is 1%, a 1% reduction in the probability of favorable immune response in 1 year, which is a small reduction. And the cost effectiveness ratio is $13,500 per reduction in favorable immune response. And this is from a societal perspective, or 11,000 here, 400 from the perspective of the payer. So the interpretation is that the pharmacy refill program results in one less favorable immune response for an additional saving of $13,500 from a societal perspective, or $11,400 from a Ministry of Health perspective. This technically is a decremental cost effectiveness ratio. And as we saw last week, a large decremental cost effectiveness ratio is favorable. So the conclusion in this study was that the PRP was cost effective relative to the standard of care because it led to a marginal reduction in favorable immune response at a savings of over $10,000, which we interpreted at the time in the setting of Uganda to be cost effective. So technically in this paper we should have written DISA, although we wrote ISA. But given that the outcome was a clinical measure of favorable immune response, this is a cost effectiveness analysis. And here is what I was talking about, the decremental cost effectiveness ratio. You remember the cost effectiveness plane, and if I added a line here to make it full, here in this quadrant you have interventions that increase both costs and effectiveness, and you're interested in the ISA, but here the intervention reduced cost but also led to a marginal reduction in favorable immune response. So the baseline estimate is right here, and that is in that southwest quadrant, in which you need to decide whether the magnitude of the savings is worth the reduction in effectiveness. And in this case, our interpretation of the reduction in favorable immune response for over $10,000 turned out to be cost effective. At least that's the way we interpreted the data. And the conclusion was that the pharmacy refill program is more quote unquote cost effective than the standard of care, and that similar task shifting programs should be considered. Next, we have cost utility analysis, and these are the gold standard analysis in which we have non-financial metrics that allow us to combine the length of life and the quality of life. And like we said, they allow comparisons of interventions across the health sector. I've already been giving this example of road accidents and depression, because depression is mobility heavy and road accidents are inherently mortality heavy. And the two main metrics are the QALY and the DALY, and in week 4 we're going to look at details of how to think about and calculate QALYs and DALYs. And these CUAs don't capture may not capture inter-health sector comparisons completely, and the reason is some health interventions have outcomes that are difficult to explicitly list as inputs into the decision-making process. In CUAs, you have to estimate utility for QALYs and disability weights for DALYs, and we'll look at that. And though there are some theoretical controversies, QALYs are generally acceptable in the field and have been used in a large amount of studies. So you'll see many studies that are cost utility analysis that measure the cost per QALY saved or the cost per DALY averted, and we'll look at examples. So here's a picture of a QALY, and on this axis we have the quality of life, and on this axis we have the length of life. And maybe an individual is born with a quality of life of 1, and 0 is death, and 1 is full health here, full health, and 0 is death. And someone is born in, let's say someone is born in full health and they live their life, and as they live their life they have problems. Maybe here they have a flu and they fall sick, and then they go back to full health, and maybe here they have accident and they break a leg, and they have a bad disease here, and then they go on and die at this point. And if you intervene and give them an intervention, maybe this was HIV, the bad disease, you give them ARVs, then it would increase their length of life here, and it would increase their quality of life, essentially going in this dimension. And this shaded area here is reflective of the number of QALYs gained by the intervention. But like I said, we're going to look at this in more detail in a coming week. DALYs are the opposite of QALYs. 1 is reflective of full disability, so it's a bad thing, and 0 is reflective of zero disability, so it's a good thing. So DALYs and QALYs are essentially opposite, and you will see in the literature, studies will report cost per QALY gained and cost per DALY averted. And that's reflective of the flipped scale, essentially, where you have 1 for full disability in DALYs and 1 for full health in QALYs. And so they are kind of opposite, area above the curve and area below the curve. But they all combine length of life and quality of life. Here's an example of a cost utility analysis, another example of one of the studies that I have done with my colleagues, and this was a cost effectiveness analysis of facility-based care and home-based care for provision of antiretroviral therapy. And at the time, stakeholders were using different methods for providing ARVs in Western Uganda, and they wanted to see whether using home-based care or mobile clinics or facility-based care in the regular facilities was most cost-effective. And we built what they call a Markov model, and we'll look at Markov models in week 6. But it was based on clinical stages of HIV, and it was basically an AIDS model, not an HIV model. So it was mostly stage 3 and stage 4 patients. But the outcome was a combination of life years and quality of life. And we'll see how we measured utilities to adjust for quality of life. Then here were the results. And as you can see, we had 3 comparators. We had facility-based care there, mobile clinics, and home-based care. And home-based care was the most expensive, $7,000 for a year of care. And the others were cheaper. And we had the incremental cost. And then we had this life expectancy column. And it allows us to calculate the incremental and the ISA in cost per life year, which is a cost effectiveness analysis. Now we also measured utilities, which allowed us to estimate QALYs in this column and incremental QALYs, and then estimate our cost per QALY gained here, which is a metric for cost utility analysis, which is a combination outcome combining length of life and quality of life. So this study technically was a combined cost effectiveness and cost utility analysis. And because the ISA was high for home-based care and mobile clinics, $2,800 and $2,600, at the time GDP for Uganda was about $300, so 3 times is less than $1,000. Our conclusion was that facility-based care would be the most cost-effective because mobile clinics and home-based care had ISAs in costs dollars per QALY that were higher than 3 times GDP. So our conclusion was that facility-based care would be the way forward if the country wanted to choose a metric, because the others had a cost per QALY that was too high. So here's the second example of a cost utility analysis, another study performed in Uganda, and this study was performed at the IDI, and although I wasn't part of the research team, some of my colleagues at the IDI were the ones who did this study, and it was evaluating the cost effectiveness of combination antiretroviral therapy for preventing mother-to-child transmission of HIV. And the background of the study is that you still have 12 million HIV positive women of childbearing age in Africa every year, and they account for 1.4 million pregnancies. So you have that risk pool, and this model was to see whether combination ARVs were cost effective for preventing mother-to-child transmission of HIV. They used a decision-based analytic model. We'll see decision modeling in week 5 and 6 of the course. And so here are the results of this PMTCT study, and I don't want to go into all the details of this table, but I want to point out the costs. So you had cost difference, cost offset, and then you had the incremental cost, which is here, and then you had the outcome measured in DALYs averted per patient, which is here, and then you had an ISA in cost per DALY averted. As we said, DALYs are a bad thing, so you'll find studies which say that the ISA was measured in costs per DALY averted, and for QALYs it is costs per QALY gained. So in this study it was costs per DALY averted, which is also a cost utility measure. And as you see across this last column, the cost per DALY averted wasn't very high. So the conclusion was that in Uganda, ART appears to be highly cost effective for prevention of mother-to-child transmission of HIV. And it's because the cost per DALY averted is less than 1 times GDP, because the GDP of Uganda is, in real terms, is at least $500. So all these costs per DALY averted are lower than $500. So that's why the conclusion was that ARTs for PMTCT are highly cost effective. So they said that given the additional public health benefits of ART, efforts to ensure that all pregnant women who are HIV positive have ARVs for a lifetime should be intensified. So in the last part of this week, we're going to look at cost-benefit analysis. But before we leave part 2, let's summarize using our Malawi Kwachas. So if we had our study between intervention A and intervention B, and in Malawi Kwachas, and this was our cost-effectiveness ratio, we would have cost of A in Malawi Kwachas minus cost of B in Malawi Kwachas. And then we would have maybe effectiveness of A minus effectiveness of B, but the effectiveness would be in our clinical measure. This would be a cost effectiveness. But if it was QALYs or DALYs, then it would equal to a cost utility analysis. So thank you very much, and I will see you in the third part.